Thank you, friends, colleagues. I'm actually very happy that I'm here to see a lot of entrepreneurship in the field of healthcare delivery and to see some very exciting facets of what has been presented in a field which I've been actually pioneering new technologies for the last close to 3 decades, and of which I've led from the forefront, not just in India, but across the world. And of course, we've been very smart over the last 30 years in developing new sciences, new research, new technologies for the betterment of cardiology patients. And today I'm actually going to give you some of my thoughts. I could have stood here and given a lot of technology gyan, but that's not the purpose of my standing on the podium today amongst you all, because I'm here to actually create a wave of a new thought process for this country, of which all of you are a very integral part. And so you may call this some of my musings, some of my, say, independent thought processes when I sit and am wondering how to actually change the healthcare delivery in this country. Now, when we look at this country, and it was even in the medical college, that was a long time ago. I don't want to tell you how many years ago it was, but it was a long time ago, that we were taught that an Australia gets added on to India every year. 40 years ago, an Australia was getting added on to India every year, and nobody ever saw that the biggest stake, the biggest area, and the biggest future in this country lay in actually protecting and providing healthcare delivery to the population. And so whatever we're seeing now, and any of the government initiatives which we see over the last 10 years is too little too late, only because for years and years an Australia got added onto this country and nobody bothered about it. And a 1.2 billion population, on one hand, could actually represent for many a great opportunity, but really, if we could consider healthcare delivery is one of the biggest challenges. And while we may talk about universal healthcare for all, and universal healthcare believes in availability, quality, and affordability, even if we just get to the availability of those issues, let alone affordability and quality, that itself is an impossible task. So while we talk about it, let me actually explain to you what is truly happening. Well, affordable healthcare is unfortunately an arbitrary definition, because what may be affordable for in this country, and therefore we have to define what is affordable healthcare, and I do believe that the systems now can only achieve their outcomes over the period of time if we all start believing that there are going to be 3 silos of healthcare delivery. There's going to be healthcare delivery for the non-affordable, which has to come free, which has to be highly subsidized to the care providers and healthcare deliverers. There has got to be a middle, which is to be subsidized healthcare delivery, which will still cost money, and then there's going to be left alone those individuals who can actually pay for themselves at a heavy cost, and they should be allowed to pay for themselves and not come in any pattern of any form of subsidized healthcare delivery. And that is the group which will actually subsidize the other patterns as we go along this country. But I say this with a very important expectation. I say this because entrepreneurship, research, science, academics will only progress if these 3 buckets are very well defined, because every person who goes into healthcare delivery cannot be assumed to be a philanthropist. And I'll come to the next aspect of this whole unfortunate dichotomy in the thought process and the execution. While we talk about frugal innovations, and I tell you, frugal innovations are the way to go in this country. We have to create such innovations as we are seeing, and they have to be frugal enough to be affordable. But I also say this, and I've been a part of some of those frugal innovations, and I don't want to bring the slides up, like we've created an EICU, whereby we have attached tier 3 city ICUs, which don't even have a critical care specialist, which only has a physician, to a centralized monitoring at Fortis Escorts Heart Institute, and are able to monitor every bed, real-time parameters of every critical care patient as far as Bareilly, Ranchi, and even remote in Khulna in Bangladesh, and are doing rounds of those patients, advising a physician on what to do, and have actually saved lives, decreased their antibiotic use, and improved outcomes by a single 3,000 square foot area which has monitors fitted all around at Fortis Escorts Art Institute. We now have 350 beds attached to us. We are actually ramping this up to a model which takes care of every patient in the remotest place of the most critically ventilated patients at a cost of less than 500 rupees per patient per bed in a day. But that said apart, let me just go on to the bigger issues. That technology, science, research, still, however frugal, comes at a cost. And all of us and all of you are here not just to provide those services to the patient, but also have the rewards of all this. Perhaps healthcare delivery is one area in which the government, unfortunately, has been blinded enough to see that everything should be a philanthropy and nobody should gain from it. I think it's a reaction of the past where the government had a totally non-respondent attitude to healthcare delivery for years till it went out of control. And what happened to the default strategies of the nation was that the private healthcare sector grew. And this uncoordinated private healthcare sector of healthcare delivery grew into a more organized sector, which became a very integral and important part of healthcare delivery, but at a cost to the patient. But that was all a default strategy of non-activity of the government over the years. I hope you understand that. Otherwise, this would have been a regulated healthcare planned out delivery model created 30 and 40 years ago, but it didn't. And we cannot react to that by saying that every private provider, be it you as innovators, be you at vendors, be it any healthcare, organized healthcare deliverer, be it a nursing home, are all unscrupulous people trying to make money at the expense of healthcare. None of us are. But the important aspect is, why should healthcare delivery from innovators and executors be always considered philanthropic? The unfortunate aspect of a public-private partnership, which actually is perhaps the only way to deliver healthcare in this country if we want to go the universal healthcare model of affordability, quality, as well as accessibility or availability, has to be a partnership between the government and the private healthcare. It cannot happen otherwise. It will never happen otherwise. And if today you hear little sparks of those public-private partnerships, believe you me, those are just instances of these meetings happening and showing what can it be done, but there is no real mission and belief that that has to go forwards. Now we have two of these verticals. Look at the unfortunate aspect of this country, and I therefore believe, and I have my own apprehensions whether this will ever get executed in my real-time life, is the single fact that these two verticals of healthcare delivery, the government and the private sector, which provides, the private sector which provides majority of the healthcare delivery in this country, the government which has the maximum reach and the beds, are not even meeting in a center point where both believe that can we create a win-win for everyone in a uniform manner. There's a lack of trust, and the trust is a perception. The perception is right from the private players sitting across the table and saying that I don't think there is transparency, there is no efficiencies, and I don't believe that you have the abilities to run this in a manner which is sufficient enough to deliver good health care. The government, on the other hand, loses trust in the private players completely, believing that they're only in it for trying to see how much money can be made out of a pattern which is more voluminous. There's a complete lack of trust, and the government also believes that it should come at a very low cost, which is unsustainable for most of the organized private sector, because quality is always missed out in these discussions. What is going to be talked about is at what price can you deliver healthcare. Nobody in any of the meetings that I attend on the government side ever lays out the quality issues and saying, you will actually, are you able to deliver an angioplasty with a good stent, with a mortality of less than 0.2%, with a restenosis which is less than 5%, with making sure that the patient doesn't come back to the hospital in the next 1 year, and making sure that he has improved quality of life on all the international parameters, making sure that he doesn't have a heart attack during your angioplasty, making sure that he doesn't develop blood transfusion and kidney failure during your angioplasty, and nobody ever asks me my outcomes, though they are thrilled if I say that I can do an angioplasty at 20,000 rupees, and they say, here, you are the guy we looked for all the time. It doesn't matter if I kill that patient. Unfortunately, quality has gone down in the whole device of delivering healthcare. And the public-private partnership needs to develop along strong models of trust, belief, making sure that it is a win-win for all, making sure that innovation, science, and research gets rewarded nicely, not exorbitantly, and actually that it actually takes into account delivery of quality to the patient. It is unfortunate that if I have to say that I will actually be able to open up cath labs across this country and do bypass surgeries at 40,000 rupees, it would be unfortunate that you would actually say, what a great guy this guy is, that he can actually now transform a model to 40,000 rupees. It would be unfortunate if I did not have the same outcomes at 40,000 rupees in a small town, maybe even Bareilly, maybe even smaller towns, and I couldn't deliver it at the same cost, because that patient needs the same quality and the same outcomes as I do it at Fortis Escorts Heart Institute. And if I couldn't deliver it, then that is not healthcare delivery at whatever cost it is. Yes, if at 40,000 I created a model which exactly provides him the same graphs, he has total arterial graphs, he has actually the best outcomes, he goes home without an infection and without death, and the mortality rates are the same, then I say that 80% of what I do at Fortis Escorts Heart Institute, if it gets delivered downstream into tier 2 and tier 3 cities, then I have created a robust model of healthcare delivery. Otherwise, I have not. But the other aspect is that look at the sadness of the whole issue. We have the National Rural Mission, which has to work towards the non-affordable people in the villages, and they need 80% of the disease processes, in fact 90% of the disease processes, are prevented by sanitation, hygiene, nutrition, good water supply, and vitamins, and antibiotics. And that is all that's needed to prevent 90% of the disease process. It takes care of everything. In case of diabetes, hypertension, everything would be taken care of. And yet, our great, one of the finest institutions ever created in the public space by this country is the All India Institute of Medical Sciences. And look at the irony of the fact that we talk about modifying healthcare delivery when All India Institute of Medical Sciences should have been looking at that small proportion of patients in this country who could not otherwise be treated by any other district general level hospital, actually sees 1,200 cardiology patients in the outpatients today, and 99% of those patients they are trying to screen is chest pain, which may be abdominal, which may be perhaps a gallbladder pain, which may be something else, maybe intestinal pain. And there's only 1% of those who actually require All India Institute of Medical Sciences services. And look at the waste of energy and time of those greatest level of doctors who could have actually revolutionized the healthcare delivery and transform the ability to do highest level of procedures on those small proportion who could not be treated at a district general hospital level, who could not be treated at some of those centers. And yet we have a non-existent tier secondary level centers. We have non-existent. Which district general hospital do you remember which can actually even do a laparoscopic cholecystectomy? Why should a laparoscopic cholecystectomy, which is a norm, become a super specialized services? Why couldn't it be delivered at a district general level? Why couldn't the government actually transform these secondary hospitals into a better healthcare deliverers? The reason is, of course, we know that they are overcrowded, there are inefficiency, there's lack of equipment, there's lack of expertise. But when we revolutionize all this, how come we accept a healthcare delivery? And I ask you all this sitting in this hospital, many of you come from those towns, many of you come from smaller towns. I also come from a smaller town and I grew up. How come I accept now that I have a district general hospital from where I'm even supposed to have a heart attack and be able to go in and have a lysis and maybe even an angiogram, and that's how the whole world around us functions? And how come that a private hospital opens up right next to our district general hospital and builds 50 beds and 70 beds and can charge exorbitantly for anything which is done, and yet we accept that model as a healthcare delivery model in the country? And that's because the deficiency of private and the public sitting on opposite sides of the table and not actually believing that it has to be a win-win for all. Had the government always believed that it has to be a win-win, we would see a greater growth of innovation. And the biggest example of this, and I'm not in the critique of the government, I'm actually saying that it's time to think back, that if we've got to have a goal, a mission, and a belief, then let us actually go on the paths where it can be accomplished. There's no point creating visions and beliefs and building dreams if it's not going to be transferred. And I know, and most of intelligent doctors who have the experience of the last 30 years of healthcare delivery and science and research and academics, and have shone across the world, also know that the pattern does not exist, or the mission is only in paper and isn't going to be translating into the real healthcare delivery that we want to see. And that's why the urban mission has to falter unless we actually start believing on the paradigms on which, the pillars and strengths which has to be built. I want to say to you that one of the recent things which happened was the stent became a part, and you know the stents which actually save human lives from the coronary artery disease, of which we are the capital in the world, became a part of the national list of essential medicines. And I thought that was a great thing which the government did. And I actually support that wholeheartedly. I support that with the fact that if that device is essential and 500,000 of those are implanted in a disease process which is a national problem, then the price of it has to be capped, especially because the government actually knows the price at which that device comes in, and finally also knows the device at which it gets to the patient. And the range can be sometimes exorbitant and deplorable. But the real issue and the bigger challenges I hope the government actually will see and will have to see is that at the expense of the cost, at the expense of putting a ceiling onto the cost, at the fact that the ceiling is going to be some cost, we cannot lose quality at that cost. We can put a ceiling to it, but the ceiling has to be a win-win for everybody. It has to be win-win for the stakeholders. And one of our stakeholders, apart from the industry, apart from the clinicians, apart from the government, is also the patient. We actually have to think very strongly and to develop in between, in this NLEM, is how do we differentiate between stents? A stent is not a stent is not a stent. And if it's going to be a $1 shop for all, then it's $1 and everybody will fit into that $1, but it'll be outdated products. They could be made in garage products. They could be poor quality, and especially when we live in this world, in this era, in this country, without actually having robust quality norms, even defining anything, we're actually going to be stifling innovation. We're going to be stifling, perhaps, creation. We have to start differentiating as to what the ceiling is going to be for devices or stents which have academics behind it, which has strong research behind it, which has large trials behind it, which have been shown to be safe and effective over a 5-year follow-up in large and thousands of patients with proof, versus a 100-patient study, and saying that is also as good as the one which had a 10,000-patient study. FDA, by the way, and perhaps I'm the only clinician of India who has ever presented before the FDA for a device approval. And I did that for the absorbable stents because I've been very associated with this new innovation of absorbable stents, of which I'm considered one of the world leaders in its use across various subsets of patients. And that's why I was the only Indian ever to present at the FDA approval device panel on the 13th of March. I actually witnessed the FDA device panel. That was for the approval of one of the most revolutionary technologies for the treatment of coronary artery disease, absorbable stent. And for the whole day I sat and I did my presentation, and there were 5 other presentations and the trial presentation. And my experience was also taken majorly into account, as I have one of the largest experiences in the world with the device. FDA devices panel had an open panel. It actually had public sitting there. It actually had press sitting there. It had scientists sitting there. It had every company's people sitting there. And this panel, of course, of 15 individuals had medical personnel, had social personnel, had scientists. They had absolutely everybody who went grilled. Not just the company which did the trials, not just actually talked to the doctors who had experience and use of it, which were very few of us. There were only 3 from the rest of the world. But it actually also, that panel drilled the FDA, and it was an FDA-created device panel. So it also did the FDA that what do you have against this? And what is, because FDA gave a set of slides to the device panel, and it's an FDA device panel, and yet it grills the FDA. And after that, the 1-hour discussion on whether to approve was actually heard by everybody. Their discussion of 15 was heard by a room of 150 people, open discussion amongst themselves for 1 hour as to what should be done, what is the deficits, what are the risks to the patient, will it be right for the patient, is it time to approve it, are we okay with these trials, do you need trials to be done? And at the end of that 1 hour, openly a vote was taken, which was initially blinded. The result came out as 10-0 in favor of bioresorbable scaffold to be approved. And then actually every person was asked and told, you voted no for this, and it was just 3 things they had to vote for: safety, efficacy, and should it be approved? Yes, no, yes. And they did that, and then each one was told, you voted this like this. Why did you vote no? Why did you abstain? It was such a transparent. What I'm trying to say is, here is a situation where stents come on board, NLEM. Now there's a subcommittee looking at it. And the subcommittee which is looking at how to do it, and it has the numerous challenges I enumerated, and I hope those challenges get met, because we don't want quality to be sacrificed, we don't want innovation to be sacrificed, we want the best stents from across the world to be coming into this country. We want to actually encourage our own industry to compete to create the best stents in this country. We want robust systems of quality monitoring. We want foreign investments to be coming in to create those stents here, but we don't want that under the same $1 for all banner should be made in garage stents, which perhaps I could also make, and have a 100-patient study, which is all that is needed in this country to have an approval of a device. And if we go that route, we perhaps would have actually sacrificed the lives of our patients for the sake of a $1 shop. So I believe that there should be $1 shops which have cheap stents. There should be $5 shops, and there could be $10 shops as well, because that's where innovation, science gets rewarded. There has to be a reward for actually taking the world forward in saving lives. For at the end of the world, it is the lives that we're trying to save, and there are devices which actually help people to have better outcomes. And the final stuff is, interestingly, while these subcommittees are formed by the government, the reason why I can't see all this meeting in the future is none of these subcommittees about all these stents that you're going to see on the NLEM, in the discussions about all what I've said about the stakeholders, in the discussion of every aspect as we go forwards, are we seeing one person from any private field in that? They're all government cardiologists. I'm not saying they're good, they're not bad and good is not the issue in my mind. The bad and good is not the issue, but the issue is the mindset. the government has to move away. For a person, and there are many others like me in this country, who have actually been at the forefront of innovation and creation and delivery across the world, who the world respects, still will not find a place on a government subcommittee, because theoretically the government's mindset perhaps maybe that if you come from the private sector, you're biased towards profiteering. You're not biased towards healthcare delivery. And I think that is perhaps my bottom line message, that while all of us create, innovate, build all those models with a hope that we deliver healthcare at an affordable cost, but we also get the rewards of those innovations, and we can partner the government in making healthcare available for all. But let us not believe that it is that we are at suspect. We have biases. We should be looked upon as profiteering, and we should be philanthropic. That's not the way to go for this. Thank you very much.